Medical Specialists Associates, making medical education more accessible.
Hello, this is Nazir Habib, and I welcome Chris Voscopoulos back since we had such an interesting conversation in our first podcast. I would like Chris to expound a little bit on rapid sequence intubation and his perspective, especially and using paralytics when we go to intubate patient. So, Chris, can you tell us a little bit as an anesthesiologist, what is your experience and expertise in this area?
Sure. I guess one of the maybe interesting aspects that maybe some of the critical care anesthesiologists bring to this particular topic is that after we've done so many intubations and we've developed more confidence in our ability to intubate, because at the end of the day, when we talk about rapid sequence intubation, what we're saying is that we need to secure an airway quickly and confidently. And once we can secure an airway quickly and confidently, then once you've mastered that particular technique, then you can start looking at maybe what you would call other value add. And so what are some of the other goals and accomplishments you're trying to achieve, in that particular patient? And, from one perspective, there are a lot of ICUs that will not use succinylcholine. And so, we all know from, board questions and reading and, other training that in individuals maybe with burns or with strokes, you get hyperkalemia. And you get hyperkalemia because you have an upregulation of acetylcholine receptors. However, there's this other insidious disease in the ICU, which is far more, ubiquitous, and that is critical illness myopathy, to where you have an individual who is deconditioned for several days. And, this doesn't have to be something that is very occult. This could be something as simple as you have a septic patient who has been on pressors for 3, 4, 5, 6, 7 days, and they've been more or less rendered immobile. That could be equivalent to a stroke-like condition, and their level of deconditioning could be so great to where they can have upregulation of their acetylcholine receptors. And say if they lost their particular airway and they required reintubation, or say they were extubated and failed extubation and required intubation, that is a case to where it could be very occult, for someone not thinking about it. But in pushing succinylcholine there, they could have hyperkalemia and they could possibly have mortality. And so in the day and age, if we're going to talk about paralysis during a rapid sequence intubation, with the use or availability of Sugammadex, where you can push rocuronium in full intubation doses, 1.2 milligrams per kilogram, and you can have immediate reversal if needed, there really isn't a need to use succinylcholine. So again, in some units, out of an abundance of precaution, we just simply don't allow succinylcholine to be used because we have an alternative, rocuronium in the dosages that I mentioned. So why not add that extra level of safety?
Great. So what I'm hearing then, Chris, is that you try to avoid succinylcholine in almost all cases, regardless of whether it's a crush, burn, or renal failure patient, and you tend to use rocuronium. Can you tell us the dose of rocuronium, how quickly it kicks in, and how long rocuronium will last?
Sure. I mean, succinylcholine has been a favorite for a lot of individuals because it can, work within 30 seconds or so. But when you push 1 milligram per kilogram of ideal body weight of rocuronium in an individual, it also works at that same speed. So again, since you have that alternative, and actually, especially then you could push Sugammadex immediately thereafter and reverse. Actually quicker than what you could, wait for the reversal or actually the wearing off of succinylcholine. Why wouldn't you go that route? You add that extra level of safety to where you prevent, even if it is preventing a complication in 1 in 10,000 or 1 in 20,000 or 1 in 25,000, why wouldn't you do that, right? Because that's one of the things that we strive for in critical care, right? Is constantly reducing complications to have better and better care.
What you're saying, Chris, is that you try to avoid succinylcholine in pretty much all cases and use rocuronium. Can you also tell us the dose of Sugammadex to have available? And is it available in the ICU or is it just in the OR?
So that's something that you're going to have to talk to your ICU pharmacist to make sure that Sugammadex is available. And the dose of Sugammadex that you're going to use is really contingent upon the blockade that you currently have in the individual. So in the operating room, to where we might give our paralytic, and then a lot of time goes by, and they might have what's called a moderate blockade. At that point in time, we use 2 milligrams per kilogram to reverse. Or they might have a deeper block in the operating room, and we might have to give 4 milligrams per kilogram. However, in this particular context, it's important to remember these numbers because in the ICU, you might have to have an immediate reversal, right? You give your paralytic, and maybe you cannot get the airway, and you need the patient to breathe spontaneous. And there, the dose is 16 milligrams per kilogram. So that is something that is very important to know so that your pharmacist can help you draw up those medications immediately if needed.
Excellent. Thank you, Chris. I think we, again, received some very useful tips on managing the regular airway in the ICU or in the emergency room. So thank you for your time. And hopefully we'll have more sessions with you regarding airway and anesthesia pretty soon. Thank you.
Thank you, Dr. Habib.
For more information, please visit our website at www.med-specialists.net. You can also find us on YouTube as Medical Specialists Associates. Thanks for listening.